Hello, and welcome to the Alabama Public Health Training Network. I'm Brandon Vaughn with the Alabama Department of Public Health. Thank you for joining us today for our program, Developing a Trauma-Informed System of Care for Survivors of Intimate Partner Violence, Identifying Strategies from a Clinical Model. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handouts, sign-in sheet, and evaluation are all available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses and social workers for this program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, CE credit will only be awarded for 1 year for nurses, expiring on July 31st, 2020, and 2 years for social workers, expiring on July 31st, 2021. If you are watching this program on demand and want to receive a social work CE certificate, you will need to complete the social work test and send it in, along with your sign-in sheet and evaluation. If you are watching this program live, there is no social work test required. For social workers, if you are watching this program live, it qualifies for classroom hours. If you are watching on demand, it is considered non-classroom hours. Before we get started, I would like to introduce our presenter today, Dr. Ashley Hodges, Associate Professor and Associate Dean for Graduate Clinical Education at the UAB School of Nursing. Welcome, Dr. Hodges. I know you have a lot of important information to cover today, so let's go ahead and get started with your presentation.
Great. Thank you so much, and good morning, and thank you for joining us here for this very important topic. I do want to let you know that regardless of your position in your organization, trauma is applicable to what you do within your job and also within your life. As I talk today, one of the things I'm going to stress again and again is that it doesn't matter if you are the one who is in valet. It doesn't matter if you're the provider. Your impact on a patient can be long-lasting and life-altering. And so people very often, when they think of trauma and trauma-informed systems, think of psychiatric mental health nurse practitioners, they think of psychiatrists, they think of substance abuse counselors. They don't necessarily think of themselves as being the provider who is going to be caring for these individuals. Well, I'll go ahead and tell you right now that 85% of all individuals, 85 to 88%, report having experienced some type of trauma in their lifetime. And so we call this universal expectations. And universal expectations means that any client that you come into contact with, you can pretty much assume that they have experienced trauma at some point in their life. And so trauma-informed care just doesn't go into effect when you encounter a patient that admits to having experienced some type of trauma. It needs to be implemented with all your clients because, again, you never know who's going to be coming through the door. One thing that I do want to say as we start today, you have to understand trauma before you can understand trauma-informed care. And many of you listening or watching have experienced trauma within your life. And so take a moment to step back and think about how trauma has impacted you not only in your personal life or your work life, but what are your attitudes and beliefs? How does it affect your mind, body, and spirit? Because understanding that will also help you to understand how you address patients, how you work with patients who have also experienced trauma. One thing I'm not going to do today is use a lot of medical terms. I'm not going to use a lot of diagnoses. I'm going to avoid those because these are everyday people who have been exposed to extreme circumstances. They don't have an illness. They have been exposed to extreme circumstances. The model of care has always been you're sick, you're ill, or you're broken, and the trauma-informed approach focuses on you're not sick, you're not ill, you're not broken, but you're injured. And so we will focus on that today as well. I mostly will use the word she, and this is a personal disclaimer, because I am a women's health nurse practitioner. I've been a women's health nurse practitioner since the early 90s, and so my default is she. I do want to preface by saying that men are also victims of trauma, that men are also victims of intimate partner violence, and men are also victims of human trafficking, which I will talk about some as well. but my default is she, so I apologize up front if I continue to say she. Also, as we talk, I will address concepts that can be applied across any setting. And that is the beauty of the model that I will focus on. It's not manualized. And many models for trauma-informed care or any other types of care are manualized. The problem with that is that they don't allow freedom based on setting, on circumstances, or on the individual patient, or your individual role within your agency or institution. And so my focus will very much be on what is flexible, how this model of trauma-informed care is flexible, and how you will be able to adapt it in your own care of patients. So again, the objectives today, you saw them on the flyer: identify best practice models for trauma-informed care implementation, define trauma-informed practices and responses to domestic violence and human trafficking survivors in a clinical setting or shelter program, discuss current trends and research related to trauma-informed services, and discuss the importance of integrating knowledge of trauma-informed care when providing services. So we've already talked about why it's important to understand trauma before we get started. You may ask why I'm also including human trafficking. In addition to my role as Associate Dean at the UAB School of Nursing, I also have clinical practice. And anyone who's in healthcare will tell you their passion is taking care of people who need you. My clinical practice is women's health, and I do have a practice with a student health center at the University of Alabama at Birmingham. But about 2 years ago, I opened a clinic at a place called the Well House. Now, for those of you who are not familiar, the Well House is a residential rescue center for women who are victims of human sex trafficking. And with this clinic, this was the first time a clinic had been placed on site at a residential rescue center for victims of human trafficking. And so we were open to establishing what this clinic was going to look like from the ground up. So we're 2 years into this, and we've learned a lot of lessons. And those who've heard me speak about this before know that I'm a tattletale on myself. And so I will tell you some of the things we tried that simply did not work, some of the things that worked beautifully that we're expanding on, and areas that are challenges and opportunities as we move forward. I think some of these will probably sound familiar to you if you're working with populations that have been traumatized, which most of you are. Also, we're going to focus on how this model has been adapted to each individual client. And so there will be times you'll hear me refer to survivor-informed trauma care. And that's because the model we're going to discuss also focuses on the input of the survivor and some of the basic principles of trauma-informed care. And we'll get to that. So one thing I'm not going to do is make this a lecture on the biological impact on the brain. That is a whole semester program, and I would not do it justice in a short period of time. But what I want you to be aware of is that especially early trauma during developmental stages, but trauma at any time, affects parts of the brain and the stress hormone in the brain that can cause immediate, acute reactions, but it can affect long-term problem solving, critical decision making, and those areas are often related to attachment, sexual behavior, emotional reactivity, motor regulation, affect regulation, hunger, safety, and sleep. So when you take into consideration the biological impact on the brain, you can see, in these areas that it tends to impact, you're going to start to see some of these signs, some of these behaviors that come forward in patients. They're not sick. They're not being manipulative. They're not intentionally trying to be, quote, defiant. And we'll talk about labeling patients as defiant. What they're doing is they are displaying adaptive behaviors. And as crazy as this sounds, very often they need to be rewarded for those adaptive behaviors. And we'll talk about some of those. So much of what I'm going to present is from SAMHSA. And SAMHSA is a wonderful resource. They have their model of care is the one that I will focus on and the one that I have used to apply within my clinical settings and working with my clients. What I like about this model is they focus on the 3 E's. And you can see in front of you their definition, and I'm not going to read it to you, but I want to point out the 3 E's. One is the event. And what the importance of event means is that this is something that occurred to a patient or an individual in an environment. In some environment, under some circumstance, there was a how, there was a when, there was a where, how often. All of these factors play into the event. And think about a question that is often asked of our patients, maybe not by us, but by other people. What did you do? How did you get yourself in this situation? What does that bring to mind? People who are often put on the stand who are victims of rape. What were you wearing? It's not a personal defect. It's not a defect of the individual. It is an event that happened, and that is part of trauma. The next E is experience. Okay? So a traumatic event may happen to me and may happen to you, and it may be the same traumatic event, but we're each going to respond differently. And the reason is because of our background, our gender, our culture, our belief systems. We're all going to respond differently. So you can't say that one person should be over it because someone who was also in that situation is over it. It applies differently, and there's so much in the back related to that. Also, I want you to remember, and I'm going to stress this several times, there is no hierarchy of trauma. And I'm going to give you a good example. I've had the opportunity to meet J.C. Dugard, and you may remember J.C. Was abducted as a child and was held in captivity for a very long time, I believe 18 years, and had 2 children by her captor. And I've had the opportunity to meet her and hear her speak, and it's amazing. I've also had the opportunity to hear Elizabeth Smart speak, and in true, very amazing, inspiring, transparent, and women who are willing to share their experiences and their own vulnerability. Elizabeth Smart was captive for less than a year. So if I were to say, well, Elizabeth Smart's experience wasn't as bad as J.C. Dugard, that would be completely incorrect. There's no hierarchy. Is there a difference between being raped and beaten 7 times versus 4 times? And again, so there is no hierarchy. One thing that we tend to do, and I think it's a defense mechanism, and we think we're helping, but when someone tells us a story about something that happened to them, how many times, and think about this, how many times do you respond with your own story? You say, oh, I know. When I did this, this is what happened to me. Some people call it one-upping. I think really it's more about trying to put yourself on a neutral field with that person, maybe make the other person feel at ease. But please remember that's not necessarily helpful. You don't want to try and kind of hierarchy the trauma experience. And then the effects. The effects they're going to present with many symptoms and many behaviors. And again, we're not going to focus on this as an illness. Symptoms and behaviors. But your approach must be holistic. And I cannot stress that enough. As I go through talking about trauma-informed care, we're going to talk about holistic care. And I'll give you a very basic example, and it has to do with sleep. Many of my clients come to me and they can't sleep, or they have nightmares, and they want medication to help them with their sleep or nightmares. When you talk to them and say, are you seeking therapy? Are you seeing a counselor? Are you in a peer support group? Very often that's not something they want to be involved with. They don't want to be in cognitive behavioral therapy. They want the medication. The problem is I'm not treating it holistically. I am treating a symptom of the bigger picture. And so it's coordinating those services and having a referral system in place if you don't have them within your own organization. So sometimes you hear the terms complex trauma or complex PTSD. Ashley's personal belief is that all trauma is complex and all PTSD is complex. I will tell you that very seldom does someone experience one traumatic event. Okay, I'm going to go back to the story of Elizabeth Smart. And in one of her books, if you've ever read her books or heard her speak, she talks about obviously the trauma she experienced at the hands of her captors. But then she also talks about once she was rescued and taken into what we would consider a safe area and was examined, was relieved of her clothing, the clothing that she was wearing, and underwent physical examination. That's traumatic in and of itself, even for those of us who haven't been through those experiences. And we'll talk about how some of our tried and true rules and what we think makes people feel safe is actually to the contrary. So they experience many different types of trauma. And here I've listed some of them related to abuse. Often we think of emotional, sexual, physical abuse. Domestic violence, also domestic violence can be emotional, sexual, physical, can be financial. All of those, they don't stand alone. They're all encompassing, and they have many factors that can be built into them. Sometimes the traumatic events happen before the individual's too young to remember them. And I've heard stories of people, and you've probably heard stories too, of people who come forward years later and recall sexual abuse or physical abuse or neglect as a small child. And people who scrutinize them say, well, it's convenient they just remembered, or how could they not have remembered until now, okay? Think back what I said about the biological response to the brain. One area that it heavily impacts is recall and recall of events. Not just that they were young, which many of us have forgotten many of the even good events that happened to us as children, but they also forget the bad events. And part of that is the brain's effort to protect the individual. How many times have you heard, I went through labor delivering a baby, and it was so painful. It was horrible. It was painful. I never want to do it again. I'm never doing this again. They deliver. All the pain's gone. And what do we always say? They forget what that pain was like. And so we do it again and have another child. And then remember, oh, I remember what that pain was like. And it's our mechanism. It's how our body reacts to very stressful, painful, or traumatic events to help protect us. Also, loss, the death of someone, abandonment, neglect, separation, natural disaster, accidents, terrorism, and obviously war. I want to talk about neglect for a minute. Many of the patients that I care for have a history of neglect as children, and we're going to talk about ACEs in a minute. But have neglect as children. And this neglect took on many forms. Sometimes they were abandoned for weeks at a time by a parent. Sometimes they were not offered food, adequate clothing, no running water. But sometimes neglect is they didn't have a support system. They didn't have a family there to support them. So maybe they were being bullied at school because they didn't have clean clothes. And there's not a family support system there to help them cope. Multiple traumatic events, and it impacts the way that they adapt. I recently saw a commercial on TV, and it was really interesting, and it talked about children returning to school. And all the children they were happy because they were getting new clothes and so forth, and they were buying all their school supplies, and they were thrilled to be going back. And then other children were stomping their feet. Oh, I don't want to go back. My summer's over. I hate to go back. And I thought to myself, how is that experience translated to children who are living in poverty or who are being neglected at home? They may be thrilled to go back to school, but not for the same reasons that maybe many of us were thrilled because of their new pencils and their new erasers and to see their friends and to wear that one outfit that they got for their first day of school. I remember as a child laying those out, excited about going on that day. No one was quite as impressed with my outfit as I was, but I was excited to be going back. What if you were going back because now you were in a place where somebody listened to you? What if you were going back because now you had air conditioning or you had heat? What if you were going back and you were excited because you weren't going to be raped? You weren't going to be beaten? You weren't going to be yelled at? What if you were excited about going back because now you got to eat? You got to eat. Otherwise, you weren't going to eat. So think about the impact of neglect. Very few adults that we care for are going to go into that kind of detail about their childhood. But always, remember we talked about this universal expectations, always assume it's somewhere in the background. And then traumatic events. We know that when you have a accumulation of traumatic events or chronic stressors over time, that it can lead to trauma. So poverty, racism, invasive medical procedures, and we'll talk about how we do this in medicine, historical trauma, community trauma. And I really like this, family member with substance use disorder. We deal with that within our own communities, within our own profession, within our own practices, and maybe it is not the person who is actually the substance user, but it is a family member and the trauma they have to go through, and that is a chronic stressor as well. So as we talk about understanding trauma, remember that these cause intense physical and psychological stress reactions. Sometimes it's not even happening to that person. So what if, think about school shootings. That's probably the best example I can give you. And we talk about needing to give a safe place for our children at schools. We talk about creating that safe space. But what are we doing also? We're doing active shooter drills at school. So maybe the shootings didn't happen anywhere near their school, but they can also experience chronic stress and trauma from it having happened to a group that they can identify with. How many times have you heard of a child being killed and automatically another child who was not necessarily even associated with that other child begins to experience trauma and display some symptoms and some behaviors, some reactions that are that aren't typically like themselves? Could it be that that child associates with another child? A good example is if you're a parent and you've had a child who had a friend whose parent died. Has your child come back to you concerned that you're going to die? That's very common with children. And they worry about this. And our temptation is to go, oh, no, I'm not going to die. Don't worry. The problem is they just saw that happen to someone that they can actively relate to. And so you want to make sure that you address that appropriately. And so it's the same thing with other types of trauma. So first I want you to think about how the same traumatic event can cause different reactions and different behaviors in different people. We cannot compartmentalize, we cannot put these people in boxes. A rape victim is not going to respond the same way as another rape victim. A domestic violence victim is not going to respond the same way as another domestic violence victim. And that's why I like SAMHSA's approach, because it's not manualized, it's not a checklist, it's a way. And so for every patient you have, you can modify it, you can modify your approach based on that patient. It can cause short and long-term effects. They can relive the experience. And we see this with nightmares, with night terrors. We see this with flashbacks during the day. They can relive that experience. And sometimes they don't even know what is going to be the agent that causes them, what is going to be the activity, the event that causes them to re-experience that event. Sometimes what I see is that they become very intrusive. These daydreams, these day terrors, they become very intrusive. And the person has an exaggerated emotional response. An example is a domestic violence survivor that I cared for years ago. She came into my clinic and she was not, and I'm going to use the word not compliant, and we can get on to me in a few minutes, but she was not taking her medication for her blood pressure as prescribed. And when questioned, I talked to her and said, well, you really need to be taking your blood pressure medicine because, and I listed out all the reasons and potential implications of her not taking her blood pressure medicine. And she blew up. She exploded. She was very angry with me for lecturing her on what could happen, why she should take it. And I thought, well, this is very out of character behavior. This is not appropriate behavior. And I labeled this patient, something's not right. But did I ever stop to think that what wasn't right was that she didn't need another person telling her what she was doing wrong? That's not what she needed. Maybe what she needed is for me to ask her what was going on and what could I do to help her with taking these medications. And at the time, I didn't realize that. This was years ago. And I was very confrontational with this person. Not ugly, not harsh, but I was very professional and to the point. And I told her what she needed to be doing and what was going to happen if she didn't do it. Well, in her domestic violence relationship, what do you think she heard a lot of? If you don't do this, I will do this to you. Okay? If you don't do what I say, I will take your kids away. If you flirt, if you smile at that bag boy at the grocery store, I'll beat you so you can't go back to the grocery store. So they had heard all she wanted to hear about consequences of something she was not doing. And so it was the wrong way to approach that person. Also, it affects coping responses, relationships, and developmental tasks. And we know with children that it's a point as children that they are actively, their brain is actively reaching developmental milestones and working on maturing, the brain maturing. And when they're neglected or when they're experiencing trauma, we know that those are disrupted. And again, we'll talk about ACEs shortly. But sometimes what you see as coping responses is avoidance, numbing. You give them bad news and it doesn't impact them. Okay, I've given some of my patients devastating news about lab results, about tests, people who have experienced extreme trauma, and they're numb to it. And they don't respond. And they don't really have an immediate reaction. I've even had them ask me, well, is that bad or good? And it's not that they didn't understand the diagnosis. They truly did not understand what their emotional response should be. If I'm told I have cancer, I pretty much know what my emotional response will be. If I tell someone who has numbed themselves to having emotional reactions to stressful situations, if I tell them bad news, if we talk about something that maybe makes them uncomfortable, chances are they're going to be numb to it because their avoidance of the situation is one of their coping mechanisms. Okay? They also go to efforts to avoid thinking about stressful situations. And I'll give you an example. At the Well House, we have women, when they graduate, we celebrate. They celebrate, and it's a celebration like you've never seen, because it's an emotional time for everyone. It's an emotional time for everyone. We're thrilled that they're moving on. The other residents are happy for them. They're thrilled that they're moving on. They're an inspiration. But do you think it also causes them to be a little sad? Do you think it's a difficult event sometimes for them to deal with? Is it because they haven't graduated? Sometimes. Or is it the fear of what happens after you graduate and leave? Is it the unknown? Is it will this person be taken back into that lifestyle? And so I see them sometimes, they're thrilled about attending the graduation. But then there's some who don't feel well that day, who go to bed. And it's not that they wish ill will on that person. And the natural reaction would be, you should be happy for them. Get out of bed and come and see this. What they're doing is they're avoiding those emotions. They're avoiding that situation. And again, that's an adaptive response. Sometimes they have the inability to have positive feelings or for feelings of love. And also limited emotions and loss of interest. The last is impacts physiological responses, well-being, social relationships, and or spiritual beliefs. Again, we talked about oversensitivity and irritability, exaggerated startle response, being on guard, difficulty concentrating. Sometimes they have this terrible insomnia, or if they do fall asleep, they wake up at night. Everyone is going to be different. Some of them tell me they sleep great. Some tell me they sleep too hard. Some tell me they can't fall asleep, but then they stay asleep. Find out what their bedtime practices are. And ask them, is there anything, and this is very superficial, is there anything that would make them feel safer? It goes back to safety. I may think a nightlight will help them. To them, they may have been forced to sleep with the lights on where they were, whether it be a domestic violence situation, maybe it was trafficking, maybe it was their parents, maybe they were forced to sleep with the lights on so they could be watched. So a nightlight may not be the best thing for them, or the dark may horrify them. And do they need some kind of a light? And so take those into consideration. So one thing about understanding trauma, and again, go back to our term universal expectations. One place that universal expectations are really applied is when we look at mental health illness and we look at substance use disorder. It is so common in people with substance use disorder that it is assumed, even if not disclosed, it is assumed that there is a history of trauma in the background. And some people say, well, it's a way of acting out substance use disorder. What we know is a way of trying to help themselves very often. It's a way trying to not feel. Remember, we just talked about avoidance of emotions, avoidance of different feelings. It is a way to numb those feelings and to get away from the stresses. We also know the same thing with mental health illness, mental health disease, that they are often have a traumatic experience or multiple traumatic experiences in their background. It may not readily be disclosed, but the assumption is that that is what is underlying. And they may not disclose it up front, and that's okay. In order to treat mental health illness and to treat substance use disorder, you have to understand the role that trauma played. And so that, when we start talking about trauma-informed care, we'll get into that. So pretty much everyone knows about ACEs, the Adverse Childhood Experiences Survey. And it's really, if you want to look at it, you can go to the CDC's from 2013. And it was a huge study that included about 17,000 individuals across the United States. And it really analyzed the long-term effects of child and adolescent experiences before the age of 18 to trauma, to adverse situations, and looked at how that impacted them as an adult. There are several categories. It addresses physical, emotional, or sexual abuse, neglect or abandonment, divorce, alcoholism or drug abuse in the family violence, poverty, homelessness, lack of food and basic needs, a family member in prison, or a family member with mental illness. And what it does is it tallies a score. And the score will give you an idea of where that individual falls on the ACEs scale and what their risk is of adverse experiences as an adult. Now, I do want to preface this by saying, just if someone has a 1 does not mean, if someone's family they have a divorce and they have a 1, it does not mean that they did not experience significant trauma, and that you need to address the trauma in your care of that patient. Remember, we talked about there's no hierarchy of trauma. It's how that person experiences it. It's the event. It is the environment. It is the experience, and it is the effects. So event, experience, and effects. We see that women and men who have higher ACEs scores, we see adoption of different health risk behaviors. We already talked about substance use disorder. We also see sexual promiscuity, and that is not uncommon. And so if you have a patient who is young and has recurrent UTIs, has recurrent pregnancies, has recurrent sexually transmitted infections, then that's something you want to look into. Even if they're not being sexually abused, they're not in that type of situation, you also want to look at, are they being sexually promiscuous? And if that's the case, you want to look and see what's in their background. We also know that it leads to eating disorders, and there's been a tremendous amount of research done on the association of eating disorders and trauma in childhood. How many times have you heard, eating disorders not about their weight? It's not about their weight. Well, it's about control is what it's about. I'm not going to go so as far as to say it's never about their weight, but it's about the control sometimes of their weight. But it is something they can control, whether it be bulimia, anorexia, bulimorexia, and other types of eating disorders. I have seen in my practice many women go from, they were substance use, they used heroin, they used methamphetamine. They came away from the heroin and methamphetamine. They became heavy smokers. They became anorexic. They were bulimic. They were cutters. They began cutting. And it's very common to see these things, as these are people trying to cope. These are people trying to cope. Also, we look at severe medical complications. We know pulmonary disease, liver disease, STIs, and gynecologic cancer, because we know about the role of HPV in human papillomavirus, and then early death. So when we see the signs of trauma, these are adaptations, and I'm going to keep pushing those forward. It's not an illness. These are adaptations to the trauma. One are behavioral, and again, we talked about blowing up at being corrected, resisting any kind of transition to change. They want things to stay status quo. They may frequently seek attention or revert back to childlike behaviors. And you've heard of people throwing temper tantrums as adults. Well, you have to look at what is really going on there. Is it because they have reached their capacity to cope, and now they're in a tailspin and they don't know how to cope? And that's what we see with children very often, when they just lose control and throw temper tantrums. I always tell people the story of my daughter when she was a young child. She would get so mad in the grocery store because I wouldn't buy her a candy bar, and this is true for many children, not just my child, but buy her what she wanted in the store. And eventually she would revert to laying down in the grocery store, in the aisle, just screaming, okay? And it wasn't she wasn't a bad kid. She wasn't trying to be malicious. She wasn't trying to be mean. She wasn't being defiant. She had met her limits on how to cope. And as adults, we don't expect that to happen. But sometimes it does, because they don't have the coping mechanisms because of their exposure to trauma. You have the emotional or the physical. And again, we talked about nightmares and sleep problems. They're sensitive to noise and also to being touched. All right, let's think about what happens when someone comes into our clinic and they come in. What do we do first? We put them on the scale. That's a whole different lecture. The next thing we do is tell them to have a seat, take a seat. We sit them down. We come over and we put the blood pressure cuff on them, and we put something in their mouth. Okay, we probably put something on their finger. Do you ask permission to touch your patient? When you do, are you standing up, hovering over them? Maybe blocking their view of the door? To us, that seems so minor. That seems so minor. Let me reframe that. Someone who is the only touch they have felt for so long is abuse. And they're told, if anybody else touches you, I'll kill you. They come in. This is the first time they've been out in public in a long time. And in the waiting room, they think they saw their perpetrator. They're not sure. They were being hypervigilant, but they weren't sure. But it was really loud, and people were talking on their cell phones with the speaker. People were playing music. Children were running around. They are a nervous wreck by the time they get back to you. The only chair that was available was with their back to the door, which was horrifying. And finally, they were in a state of panic that they couldn't stand it any longer. They had to get up and stand the rest of the 30 minutes or 45 minutes they waited to see you. Everybody that came through the door, they were concerned that that was the person that was going to hurt them. So we bring them back, and in our mind, well, they're safe now. They don't know you. So you've brought them back in probably a small room. You've told them to sit in that chair or to take a seat. You start touching them, and their back may be to the door, or you may be blocking their view of the door. Think about what their blood pressure might be. What might their heart rate be? In our mind, we think they should think, well, I'm safe now. I'm safe here. But again, what's safe to them is not what's safe to you. So you need to ask, do you mind having a seat? Because here is what I need to do. Have you ever had your blood pressure taken before? Is it okay if I touch you? All right. As nurses, we are touchy-feely. As healthcare providers, we are touchy-feely. I am a hugger. I'm a handshaker. That is the type of person I am. But when my clients come in, when my patients come in to see me, who I know in my clinic, and I know they've experienced trauma, and I know they have, I don't touch them or hug them or put a hand on them until I've asked their permission. Okay? Regardless of the situation they've been in, whether it's being trafficked, whether it's domestic violence, whether it's some other type of trauma, they have had no voice over being touched or when they're touched in their genital area very often, if they're going to be hit or not hit, what got them hit yesterday may not get them hit today. Okay? So they don't know. And you can tell them. I can sit right in front of them and tell them. And I tell them who I am and why I'm here and what I'm going to do. But I call it the looking at me out of the corner of their eye. That skepticism, and that's okay with me. And instead of being angry that they're skeptical and putting in their chart, patient appears hesitant to interact with provider. What I do is I'm proud of them because that's their coping mechanism. Their coping mechanism is to scrutinize the situation they're in, to scrutinize where they are, to scrutinize who they're with and what I'm getting ready to do with them. We can work through that, but I see that they have adaptive behaviors, and I'm not going to label them. Another example is how many times as healthcare providers do we chart good eye contact? I hate that, and I've gotten away from doing that. What is good eye contact? Do I expect someone who has been beaten and raped and someone's attempted murder on them, someone's drugged them, someone has molested them, if they don't look me in the eye when I'm talking to them, do I say they have poor eye contact? Because what does that do? That labels them in a negative manner. Do I think it's probably really appropriate they're hesitant to make eye contact with me? You bet I do. And so what I'm going to do is I'm going to describe what I see. This is what I feel. This is what I'm experiencing because but I'm not going to say it's poor eye contact. Maybe they're hesitant to make eye contact, but I wouldn't expect anything different. When they stare me down, that's another approach. And I have had some that I will sit down a nice distance from them. I never talk to them standing up. I sit down with them, and they move their chair closer to me and lean forward and look me in the eye. Is that their show of dominance? Is that their show of being protective? Do I feel intimidated? If so, that's on me, okay? Because again, that is their coping mechanism. Because they have a difficulty trusting other people, and I don't blame them. The last is going to be psychological. They're very confused, and this confusion makes it hard to cope at work, to stay on task. Sometimes they can't imagine the future. And how many times have you worked with someone and you suspected something was going on in their personal life? Maybe it was abuse by a spouse, another family member, abuse by a child. And they just didn't seem engaged in what was going on at work. They seemed kind of distant. Maybe they came to work and they had a hard time getting organized. And once they came to work, they were a little frazzled. It's not a character flaw. Maybe you need to find out what's going on at home. In this area, the one I want to stress is the feelings of shame and guilt. I will tell you that for me, that has probably been the hardest thing to deal with when working with patients who are victims of different types of trauma. The shame and the guilt they experience. To me, that is so profound because not only is it the fear, the sadness, but the fact that they have taken what has been done to them and put it on themselves to experience shame and guilt. And I'm going to use both an example in human trafficking and I'm going to use an example in domestic violence. I had a patient years ago who was being abused by her spouse, and she wanted nothing done about it because she felt that he was so powerful that he would not go to jail, that there were not resources for her, and she said, I can deal with it. I can deal with it. I can deal with it. She didn't want anybody in her family to know. Well, her mother found out. And the things that were said to her is, why don't you leave? Leave. Come live with us. Why don't you leave? Sweetheart, we love you. Why have you put up with this for so long? You are worth so much more than this. Why did you go back when you were with us out of town and he wasn't with you? Okay. How many times have we possibly said those things, thinking we're being helpful? What did that do to that woman? It was shame and it was guilt. Yeah, why didn't I leave? Why didn't I take this action? Why did I? Because what that says is those are her choices. Those are her decisions. And it's saying those weren't the right choices and decisions. Okay? And don't say you can sympathize with them when you can't. You can be empathetic, but not sympathize necessarily. Okay? Human trafficking, and probably, and I've dealt with some very difficult cases over the years, and really the human trafficking case that I want to share with you is I have a young woman I cared for who was a college student, and she was doing very well in college, but she needed money to pay for college. And when we talk about human trafficking, we'll get into a little bit more of this. She had done some modeling, legitimate modeling, and quickly got involved in some more risque type of modeling that was brought to her attention by another individual, and it was more money. Okay, she ended up in a trafficking, human sex trafficking situation pretty quickly, within 2 weeks. She dropped out of college. She became addicted to methamphetamine, and she was rescued. And she went back to her trafficker. She was rescued. She didn't go back to her trafficker, but she continued in prostitution, even though she didn't have a pimp or a trafficker at the time. And her dealing with her as a patient, the hardest thing was her getting over the feeling that she was not worthy. I'm not worthy of being saved. Don't waste your time, Dr. Hodges. I'm not worthy. I'm not worthy of God's love. I'm not worthy. I'm not worth your time. I could have gotten out and I didn't. I feel so ashamed and so guilty. And the only way I dealt with her, the only way I could deal with her is to do a true trauma-informed approach. We're going to take a break, and when we come back, we'll talk about how to do that in your own clinic.
Welcome back to our program, Developing a Trauma-Informed System of Care for Survivors of Intimate Partner Violence, Identifying Strategies from a Clinical Model. Dr. Hodges, if you would, please continue with the second part of your presentation.
Thank you so much, Brandon, and welcome back. The first hour, just to recap, we talked a good bit about understanding trauma before we move into talking about a trauma-informed care approach. Because as we go through the next 45, 50 minutes or so, we're going to talk about specific adaptations, specific things that you can do within your agency or your clinic or your own practice to make it trauma-informed. Before you see, it says problems or adaptation. And what we've talked about the past hour is looking at how do we change our way of thinking in addition to making our clinic or our practice trauma-informed, but how do we also change our way of thinking? If you'll remember at the very beginning, I asked you to, throughout the presentation, to consider how trauma affects your own beliefs, your mind, body, and spirit. What are your biases? And so as we go forward the next hour, I hope you'll use what we talked about the biological effects on the brain, what we talked about adaptive responses, and changing some of the ways that we think. Here you'll see in front of you, we talk about fight, flight, or freeze. And these are really activated by danger. And very often these type of behaviors we see as problem behaviors in patients. Believe it or not, they're not problem behaviors. They're adaptations to what they've gone through. So with flight, we may call them non-compliant or combative. But what's really going on? Are they struggling to regain or hold any type of personal power? How many times have you been to lectures or have you seen movies or have you seen TV shows or news stories about the one thing that we do when patients come into the hospital or they come into our clinic? We strip them of their power and their choice making very often. And with these patients, it's no different. Flight, they're treatment resistant. We talked a little bit about that with medication. They're uncooperative with treatment plans. Well, maybe they're actually disengaging and withdrawing. Remember when we talked again about the behavioral effects from the neurological changes, the changes on the brain? What did we talk about? One of the things that it affects. We talked about their ability to engage, their ability to be able to be involved in situations, or their active effort to disengage, or their active effort not to be involved, and to be numb to a situation. And then freeze, they're passive and they're unmotivated. Maybe they're giving into those in power, okay? We think about some of the basic principles. We think about being paternalistic. And what we do when we become paternalistic, what do? We do what we think is best for them. We make decisions. We assume that role. Well, is that really the right thing to do? Because some of these patients will fight it, and it will make them never come back to see you. They want to be active and have a choice and a voice. They want to be able to make some decisions, although some things have to be done. They want to have a choice in many aspects of their care. But if they've been in a violent situation, they've been traumatized, what are they going to do? They may hand power over to you. And is that the easiest thing for you? Is that the easiest thing? If they say, here you go, you know what, you just make all my decisions. Sometimes, maybe not, but sometimes that may be the easiest thing. The problem with that is that they're not going to be compliant. They're not bought into it. And all you are doing is perpetuating their cycle of trauma. So let's talk about what is trauma-informed care. Again, I refer you to SAMHSA. They have a very, very lengthy toolkit that goes into trauma-informed care, different services, and they break it down into an entire organizational approach. So they look at every aspect, from what are the colors on your walls to what does the signage look like, what kind of language is used when we're talking to patients. They talk about processes very in depth, and obviously that's much longer, much broader than the scope of this presentation. But I encourage you to look into it. But we're going to touch on the principles that are important. As I said earlier, trauma is a different approach. You're not sick. You're not bad. You're injured. And when people are injured, they can be healed. And so that is part of our role, to come in with a holistic approach. Trauma-informed care is an entire culture shift. I, as a provider, can change the way that I act and change the things that I say and do. But if my client or my patient comes in and the person at the front desk does not treat them honoring those same principles, have those same values related to trauma, then it's all for naught, because my patient's already re-traumatized or put in a bad situation. And so it takes everyone. So I don't care who you are listening to this, it applies to you. It applies to the person who delivers their food tray. It depends. If you're in a clinic and say you have a snack bar downstairs, it applies to those people. Okay, so it's your entire organization. The key is you have to meet them where they are. You have to frame everything around what happened to you. This was something that was done to them. And then meet them where they are in their process. Assume that every situation is unique. Don't assume that what you've seen before is automatically what you're going to see again, and every patient is going to respond the same way. So this slide really highlights the basic aspects of culture change and the basic aspects of culture change that each organization needs to adopt in order to start becoming trauma-informed. And the first R is that they realize that the organization or the agency or the clinic realizes the widespread impact of trauma and understands the potential paths to recovery. There's no one way. And everybody's different. And that goes back to individualizing your care and letting that patient tell their story. Recognizes the signs and symptoms of trauma in clients, in their families, in their staff, and others involved within the system. So let's stop there for a minute. I said the staff. Okay. Some of you have heard the term vicarious trauma. And what that often refers to is, and we see this in people who have cared for others, who are extremely traumatized, who are going through traumatic events. Some people call it caregiver fatigue, compassion fatigue, whatever they want to call it, but it's actually vicarious trauma. Now, the only bad thing about that term is that it kind of insinuates, again, that hierarchy of trauma that really is not there. So, in short, if you are working with clients, if you're working with patients who have been extremely traumatized and are exhibiting behaviors or signs or symptoms or have adapted in certain ways that you're seeing in your clinic, that can cause trauma with your staff. And within my clinic, I work with women. Every time I care for these patients, they've all been through trauma, traumatic events, long history of traumatic events. And so you have to have, as a provider, a way that you can also have a mechanism to address the impact it has on you. And we see this with people who work in palliative care. They also have to have a way to be able to receive support, peer support, to address the stressors and how the trauma of other individuals impacts them as well. So an organization also needs to have in place a procedure, a process, a mechanism by which those interacting with patients who have been traumatized, that they can address it in the staff as well. The next is responds by fully integrating knowledge about trauma into policies, procedures, and practices. It's not a slap-on fix. It's not a Band-Aid. It's not putting a poster in the women's bathroom. It's not an easy fix. It's really changing the way the culture works. And I'll tell you, a good way to do that is through role play. And then resist re-traumatization. And we'll spend a lot of time on re-traumatization. So again, why is it important to provide effective services? We have to understand the life situations that are contributing to the person's current problems. And then current problems and the people we serve may be related, again, to traumatic life experiences. People who have experienced traumatic life events are also very sensitive to situations that remind them of the people, places, things of the trauma event. I always tell my patients when I sit down with them, I tell them who I am. I tell them who I work for. We discuss their rights to privacy, but we also discuss their limitations to privacy. Another thing I tell them is, I'm going to ask you questions I need to care for you. I'm not going to ask any questions out of curiosity. If there's something you feel I need to know, you're welcome to tell me at any time. But I'm not going to probe and ask you questions that I don't need to know to take care of you. And it's amazing, the look of relief that comes upon them, because they say, whether they've been involved with law enforcement or other types of providers or in therapy, they've told their story over and over and over again. And their story has suddenly taken the highlight of their life. That is kind of the reel that continues to play, and that's what everyone wants to know. And I remind them, you are not your story. You are more than your story. And so if you want to share it, you're more than welcome to, but don't feel obligated at all. So be careful what you ask, and we'll talk about things not to ask and things to ask. Also, the reminders, some people call them as triggers. Now, avoid using the word triggers in front of your patient. Triggers, the word trigger, always has kind of a connotation of violence, right? And so if you use triggers and someone has been abused physically or threatened physically, that may have a negative impact on them. So I just say, what type of situations cause you distress? What type of situations are you uncomfortable with? I will tell you, every once in a while the word trigger will slip through my mouth, but I make an effort to avoid that in conversations with my patients. Here I just put a diagram, and really I just wanted to show that this is an example of a clinic and how they conceptualized what trauma-informed care looks like in their setting. And they divided it into environment, screening, response, and foundation. And again, the foundation are looking at the trauma-informed values, and we're going to cover those in a minute, really looking at the values of trauma-informed care and getting buy-in. You have to have that solid foundation to even move forward. All right? And people have to address their biases. There are going to be biases. It does not make them a bad person. It does not make them it doesn't mean they're not committed to the mission and vision of your organization and committed to trauma-informed care. They come into this with their own life experiences and possibly and most likely their own traumatic events. Partnerships. And then again, support for providers. Look at the environment. We're going to talk about what an ideal environment looks like. We're not going to go into paint colors, but again, if you want to go to SAMHSA's, their resources, they go into a lot about the environment, but we will talk about it a little bit. Screening, we're going to talk specifically about screening. And then what is your response? What are you going to do if someone discloses that they're being physically abused, or they're being sexually abused, or they're being trafficked? What is your response going to be? And I don't just mean what's your clinic going to do, who's the referral, who's the notification, what's mandatory reporting. I'm not talking just about that. I'm talking about your personal response, okay? Your personal response. I had a patient not long ago come in, and she was devastated. And she had been trafficked. And she had been in a situation where she was in a trailer park. She was left in a trailer park by her trafficker. And her trafficker had not picked her up yet. And she wanted a shower. She hadn't had a shower in days. And she told me, she was, Dr. Hodges, I just wanted a shower. That's all I wanted was a shower. And so this one man came out of his trailer. And she said, can I please just take a shower? And she had been beaten. She was malnourished. She was pale. She looked like she had really been through a traumatic event. And she goes, sir, can I just use your shower? And he told her that sure, she could use his shower as long as she performed oral sex on him. And that's what she did. And she waited for my reaction to see what I was going to do. Now, did I go, oh my gosh, oh my gosh. No. Inside, was I grieving for her? Yeah, I was. But also, did I sit there and look stoic, like it had no effect on me? No. No. Because let me tell you something about women and men who have been traumatized. They've got a really good meter for when you're not being truthful. And if you're not being truthful about your emotions, chances are you're not being truthful about anything. And I looked at her and she goes, Dr. Hodges, all I wanted was a shower. And she said, and that's what I did for my shower. And she waited and she looked at me. And the therapeutic response would be, well, how did that make you feel? Well, I know how that made her feel. Okay? Remember we talked about shame? Remember we talked about guilt? I told her that I was so sorry that she had been through that situation, and we were here to help her. I wanted her to know I felt the impact of that, but I wasn't going to cry. I wasn't going to come back with another terrible story to try and make her feel better. I just acknowledged that, you know what? Her emotions, her feelings, they're validated. They're validated. And you know what? That's what we're here to do. So my own personal response, your own personal response is important. So we talked about the beauty of SAMHSA and their principles, and really these are values. These are values that can be applied in a variety of settings, a variety of populations, and these are things that everyone at all areas of your agency need to take into consideration. We talked about there's no hierarchy of trauma. Well, there's no hierarchy of trauma-informed care either. And the impact on the person who checks them in your clinic can be just as profound as the impact of the person who does their pelvic exam. Okay? And so it needs to start with everyone. So these values have to be understood by everyone. And the nice thing about this, as opposed to some other models of care, not all, but some, is that this is not a checklist. This is a way that this can happen, all right? The first is safety. So throughout the organization, staff and the people they serve feel physically and psychologically safe. Well, safety looks different to everyone. Remember, we talked about how the woman should have felt safe when she went back to have her vital signs taken, but she didn't. But ask people what would make them feel safe. Some people want the room door locked. Some people want another person with you. So, and obviously, if you have to have a chaperone for exam, obviously that's another thing. But when you're just talking to them, they want somebody else with you. they want nobody else with you. And if you need to have a chaperone, you're going to have to help them work through those issues. So what is safety to that person? What makes them feel safe? And safety starts in the waiting room. The layout of the waiting room can greatly impact whether they feel safe or not. I tell people, don't have all the chairs with their backs to the door, because people who've been traumatized very likely may not sit in your chairs because they don't want their back to the door. Trustworthiness and transparency. Make sure they understand their options, okay? There are things they have control over, all right? There are things that you have to do, and you want to discuss that with them. I'll give you an example. When I go to draw blood work on my patients, they live in a communal setting. Many women live there. And so there's certain things I need to test them for, since they're going to be living amongst other people. For some, they were IV drug users themselves. For others, and we see this in human trafficking, they were being injected by their traffickers. This may be a very traumatic re-traumatization in either one of those situations. So we talk about it. We talk about it. I ask them, what can I do to help you feel safe and feel comfortable in coping with having your blood work drawn? I'll tell you what really helps a lot of times, as simple as this is, I keep sweet tarts in my office, in my clinic. Very often, if they can have candy, that helps. That is very superficial and very simple. What's an example, okay? Other times they want somebody with them to hold their hand. Sometimes they want the nurse, sometimes they want a family member. Talk to them about what's going to help. Sometimes they want to lay down, sometimes they want to be right up and watching it. But ask them. Last time I had blood work drawn, they put the tourniquet on my arm, and she goes, okay, look away. Why? Why do you want me to look away? Well, some people don't like seeing their blood work drawn. No, what I don't like is having a needle stuck in my arm when I'm not expecting it. I would prefer to watch, okay, to have blood work drawn. And that's just my personal preference. Think about people who've been traumatized and had no choice. Be authentic and be clear. Those are very important. Don't wish-wash around. Be very clear what you need to do, and be very authentic and truthful. What you're here to help them, and there are things that they have control over. I will tell you that when I see them for the first time, because they're in a residential center, I know I'll see them every week, but I don't have them undress at all. I don't have them undressed. I can reach down in their shirt and up their shirt to listen to their heart and lungs if needed. But I don't have them put on a gown unless there is a strong indication that I need to do another type of exam. But that is only with their agreement, because we have to be partners in care. You also want to directly address the limits of confidentiality. If you feel that they are at risk of harming someone or harming themselves, know what your legal responsibilities are and know what are the types of things are reportable, but also know what the process is within your organization. Peer support. So peer support does not mean that it is a top-down type of help, type of group. Peer support are people who have experienced similar things that are on even level with this person. Okay, that they can relate to trauma, they can relate to the response, and these are people who can provide them peer support. Peer support is so important when working with patients who have been traumatized, and we use them very often with people who've been trafficked, in women or men who have been trafficked, actually working with others who are new in that recovery process. It's not peer counseling, it's peer support. Some examples of peer support that we know that work are what about NA or AA. Those are examples of peer support. Also think about rape crisis response centers. They are very often peer support. These are individuals who have had a similar experience to help that individual through the process. So that's a very important thing within your organization. Collaboration and mutuality. Have you ever heard the term, one does not have to be a therapist to be therapeutic? I've heard that all along because often I'll make comments. I'll say, well, I'm not a psychiatric mental health nurse practitioner. I'm not a therapist. I'm not a counselor. I'm not a psychiatrist. I'm not a psychologist. But again, one does not have to be a therapist to be therapeutic. Okay? That's kind of where this comes in. But when you're establishing this relationship, how do you establish the relationship of a team effort in caring for your patient without crossing boundaries? Okay? Because we do have boundaries with our patients. We do have to maintain those personal boundaries. All right? The one question I get asked a lot is, do you Facebook? Are you friends with your patients on Facebook? No. No. There has to be that boundary, okay, between what I'm doing in my professional life and my personal life. But in my professional life, I still have to find a way to connect and to establish trust and for them to see this as a mutual give and take relationship. And I will tell you the best way to do that is be authentic. Be authentic, be true to them, be true to yourself. Don't hide your emotions. Don't become a blubbering mess, but don't hide your emotions. Validate their feelings. You don't have to be so stoic all the time. It's okay, all right? I always say in my clinic, I don't wear a lab coat. And some people argue with that. They say that continues to establish those boundaries of professional relationship versus personal relationship if you wear a lab coat. And my argument is I don't wear a lab coat because, to me, that represents power. That represents a hierarchy that puts the patient beneath me. And even though it may not be reality, it may be perception. But with my credentials and my degrees, and you know what, that's not important then. There are other ways that you can establish boundaries if needed. Probably the most important one is empowerment, voice, and choice. And I will say that this is so powerful because not only does it apply to the patients, it applies to your staff. A voice and some choice. And empowering them to make decisions. And I'll tell you, those decisions can be very basic, but giving them an option. Not only does that make them more likely to buy into your plan of care, more likely to be open, but that's also going to, by giving them a choice, it gives you insight into their ability to make decisions, to think critically. So it's beyond just them feeling empowered. It also gives you information about where they are mentally. And then cultural, historical, and gender issues. And I'll tell you that all trauma is content specific. Go back to when I gave you the definition again. And we talked about event and we talked about experience. The event, remember, it depends on who, what, when, how. Okay, and we know that men and women respond differently to trauma, and sometimes they experience different types of trauma. Okay, so gender matters. Culture really matters when we talk about the experience and how people perceive what happened to them. And that has a lot to do with culture and their back history, how they were raised. What is their ethnicity? What is their race? What geographic area did they grow up in? Anything that can contribute to their cultural beliefs and how they view experiences can directly impact how they perceive the traumatic experience. So let's talk about screening and assessment. The questions that you ask, you need to ask them to understand. All right? And again, I always tell them, I'm going to ask you questions that I need to ask you to take care of you. But it's so I can understand how to help you. So timing, okay? Let's talk about timing. When someone first comes into the rescue center, the last thing they want to do is answer questions about their drug allergies. and answer a lot of detailed questions. You know what they want to do? They want to sleep. They want to sleep. Are there certain questions I need to elicit? Absolutely. So if someone comes to you in your clinic, where it may be, or on your unit, and they have experienced severe trauma, okay, and this can be any type of trauma, the one thing that you want to do is assess your timing. Now, if this is your only opportunity to see this person, you're going to be a little more pressed for time, but it's on you to determine what are essential questions, as opposed to pushing them as far as you can and getting through whatever you can. You pick and choose what's important if you need to do that. But in a residential setting, it's much easier. Again, you want to approach with a very matter-of-fact attitude, because this is profession, but also you want to be supportive, and there's a way to do that. Respect their personal space. Again, I said, I don't stand over my client or my patient when I'm talking to them. I sit with them eye to eye. And if they shift in their seat, I don't shift with them, because chances are they're trying to find a place where they are comfortable in talking to me. So very often I will pull my chair directly in front of them and I will adjust it to be exactly where I need to be. Now, am I eyeballing them? No, because they may not want to make eye contact. I sit back in my chair and I listen to them. I give them an opportunity to talk. But very often they don't want to make eye contact. And the body language of not wanting contact with you is so strong. And you may see this in any patient who's experienced trauma. Very often they come in and their head is down. They won't make eye contact. They'll pull their extremities in close to their body and they will shift away from you. Women who have been victims of domestic violence, when they shift sometimes, or any type of physical violence, when they shift, they may do it. You can see them battling with themselves about shifting away from you, because what likely have they been taught or punished for when avoiding situations? Okay, so don't chase them down. You allow them to come back to you, but just stay very approachable and let them come back to you, but respect their space. I always ask them before I touch them, is it okay if I touch you? Okay. Some people will say no, others say yes. Adjust your own tone and volume of speech. And when I am busy, I tend to talk really fast and really loud. And so I have to force myself to take a deep breath and sit down with them, because even though I may have patients lined up, I have to adjust the tone of my voice. And the last thing you want to do is sound condescending or angry or rushed, but also the tone of my voice. Also, these are very sensitive things they may be discussing, and they certainly don't want you repeating it so everyone in the hall can hear. Provide culturally appropriate symbols of safety, so that takes being culturally aware of what symbols are appropriate for what individuals. Again, be aware of your own emotional response. And if you need an interpreter, use an interpreter. Elicit only the information necessary. Give the client personal control of what's possible. If you can give a screening checklist, that's great. I will tell you, I generally don't do that with any of my clients because to me, body language is so much more telling. You know, I'll tell you from a human trafficking standpoint, it would make life a lot easier as a provider if they could sit down and me go, okay, and have you been trafficked for labor or sex? And they'd go, yeah, I have. That would make it like, that isn't the way it works. Okay, so you have to be able to gauge their responses to questions. How many times have you been talking to someone and just their response, you can tell that you've hit something that's meaningful to them? This has happened to me many times when I've done presentations, sometimes in small groups, sometimes to large audiences. If I'm talking about violence, I'm talking about trauma, I'm talking about sex trafficking, I can see sometimes someone's personal response, and I know that there's something that rang true to that individual. I've had people come up to me afterwards crying and say to me, you told the story of my life. How did you know? okay? And because it touches them. So when you're talking to them, sometimes that gives you that benefit of gauging them. Okay? Be very patient and avoid judgmental comments. So what's harmful when you're interviewing or interacting with these patients? Don't use harsh, judging, disrespectful, impersonal, critical, demanding comments, okay? For some, this may be one of a few times they've been allowed to see a provider. Or they may be so scared of coming to see you because what they've been going through is going to be exposed. Their abuser or trafficker may be with them in that waiting room. And so to you, their behavior may be odd. To them, they're in survival mode, and they really don't want you to ask them a lot of questions in front of their abuser or their trafficker, okay? And so they're being standoffish and vague on purpose. Don't be disrespectful. Interactions that express kindness, peace, reassurance, acceptance, and listening, and use please and thank you. I promise you they don't hear that a lot. So use please and thank you, that you appreciate what they're doing, So what are harmful areas just in a waiting area? Congested areas, poor signage, uncomfortable furniture, cold colors, posters, and so forth. Now, I work at UAB. We call ourselves the University That Ate Birmingham. We're very large, and if you've come to UAB, and we've made great strides on having a front door with our North Pavilion, and then our Women's Center, but I will tell you, it's a big place. I've worked there almost 30 years. It's still a big place, and it's constantly changing. Think about patients who come to your facility. Where do they have to park? Did they probably have a hard time navigating, getting there? Have they ever been there before? Do they know anybody in that clinic? Or are they coming in not knowing how you're going to treat them or how you're going to act? What was the signage like? Okay, what was the signage like? I'll never forget, I've seen I have a sample of poor signage, and it was out front of a clinic, and it said STIs and had an arrow pointing that way, and then everything else was pointing the other way. Well, if I had an STI, I sure wasn't going to be the one to hang a right, because I was going to be the only one, okay? So that was terrible signage. Why would you even do that? Okay, so think about that. If the substance abuse clinic is that way and the diabetes clinic is that way, you think people are, and there's arrow, you think people are going to feel comfortable? Not necessarily. So be very careful about your signage. You want it to be clear, but think about the implications of how you have signage. Ask questions that convey, that support your belief that this is something that's happened to them. Avoid questions that assume they are responsible or they have had an active role in this. And I'll tell you, and sometimes things have just come out of my mouth. I'm guilty of that. I'll be talking to someone and I'll be so engrossed in the story, something will come out of my mouth, and I'll stop myself and I'll go, you know what, I'm sorry I said that. That is not at all how I feel. What my intent was this. It's okay. Because sometimes you're going to do that. And it's okay to say, you know what, wait a minute, I shouldn't have said that. That is not at all how I meant for that to come out. Let me rephrase that. And it's okay to do that. Ask questions. They're going to come to you with generally symptoms, and they may identify one traumatic event. But you want to ask questions that not just focus on that one traumatic event. And this is where ACEs comes in handy, because it helps you look at any adverse childhood experiences that may have led to how they're currently acting, they're adapting, and they're behaving within the clinical setting. So listen and inform. All right, so listen. What is the survivor saying to you? What are they saying to you? It may be implied. What are they not saying? Okay. How is the survivor saying it? How are they telling you this? Inform. What information do you have that may help him or her? What will happen next in the process? Let them know up front. Don't surprise it on them and they tell you this whole story and go, well, I'm going to need to call our caseworker. Well, wait a minute. Tell them up front what you're going to be doing. Okay. How can your services help him or her? You know, when I'm talking to my patients in my other clinical setting that's not with the trafficked victims, I encounter people who are victims, who've been victims of rape, incest, physical abuse, emotional abuse, intimate partner violence of all kinds. And just can you outright ask the question? Yeah, sometimes. But it's very much in how you ask it. Let me give you an example. When I was a staff nurse many years ago, we had a checklist. We had to go down where people were admitted, name, birth, all these things. And one question you asked was about substance use and alcohol use. Okay? And I was young. I'll just blame it on that. And I would say to them, and you don't use any illegal substances or drink, do you? They all went, no. And I just kept right on going, okay? Do you know, shockingly, not ever did one person go, oh, wait, yeah, yes, I do. Yes, actually, I do. I use cocaine. Don't zip past that. Gotta tell you that. No, they didn't do that. Because what was I implying by saying, you don't do that, do you? I was implying that if you do, you're bad. If I do, you're wrong. If I do, this is really going to impose on my time in getting this checklist finished. That's what I was implying by that. And I'll be honest, when I stop and look at why I approached it that way, it was because I didn't want him to say yes, because I was uncomfortable with the conversation, okay? So that's not how you approach it. So it's how you ask questions. So looking at someone, I'll give you an example with human trafficking. In women that come to my other clinical practice, not at the Well House, and I suspect they might be being trafficked or involved in some type of activity, I don't just, you can flat and come out and ask them, and sometimes they'll just admit, yes, I am working as a stripper. They may start out with that. Or, yes, I am being paid for money, paid for sex. I am receiving sex, or I'm receiving drugs for sex. Never had anyone admit those. But you can ask questions about, where do you sleep at night? Do you sleep in a bed? Do you sleep at night or during the day? Do you have your own bed? Do you sleep in the same bed each night? Does anyone else sleep in that bed? And that gives you a look into their life without automatically making an assumption of something else that's going on. But you're asking important questions. Do you have control of your own money? Do you have control of your own identification? Are you free to come and go as you please? Those are questions that help you to identify someone is in a controlling, likely abusive relationship. So think about some of the things that make you not trauma-informed. One are the use of labels, really that label people as manipulative, as needy, or attention-seeking. And I often say that many of my patients are manipulative. And I need to change the way I word it because that has a negative connotation. I mean it in a positive way. And what I should really say is they're resourceful and they're savvy. It's not that they're manipulative. That's negative. They're savvy because they had to be. Had I been in that situation that they were in, would I have survived? Okay. But they survived by being savvy and resourceful. A culture of secrecy. Within your organization, there can't be this culture of secrecy. There has to be a mechanism to discuss with other people what's going on. Environments that disempower and undervalue your staff. Don't see this as a hierarchy. Make sure the person who is valet parking, who is delivering trays, who is checking people in is just as important in this process. Re-traumatization. There are ways to re-traumatize people. And one is through invasive procedures. And we already talked about drawing blood work, and that tends to be one I really get involved with a lot. Also, pelvic exams, genital exams, breast exams. I actually had someone say to me one time, well, I don't know why she's embarrassed. She's a stripper. Well, let me name the ways of it, and so why it was uncomfortable for that individual to have to disrobe and show her breasts. Physical touch can re-traumatize someone. Personal questions that may be embarrassing or distressing. Again, that's why sometimes people say it's better for them to do a checklist, because it's not embarrassing to be asked sensitive questions. If you use a checklist, that's fine. But when you talk to them, you want to walk through that if at all possible. Power dynamics of the relationship. If I come in there and I stand over them, or I'm at my computer and I'm typing the entire time they're talking to me, that has put a definite line in between them and me. And while we have to maintain that professional boundary, I'm going to re-traumatize them if I take this "I know what's best for you" view. And unfortunately, that's the way medicine works. I know what's best for you. I know what will fix you, and they have no control. You have to be a partner. Gender of the healthcare provider. Very often, women want to see women, men may want to see men. I will tell you, in sex trafficking, most of the women want to see women, so you want to take that into consideration. A vulnerable physical position. We talk about putting people on their back in lithotomy, in stirrups. That's very vulnerable. But also we talk about with their back to the door, something that simple. So where you place them, where do you place your exam tables? If they're on the exam tables, are their backs to the door? Are they exposed completely if someone opens the door? Think about those kind of things. And then loss and lack of privacy. So I'm going to go through 3 case studies really quickly just to give you an idea. And this is actually cases that are patients of mine. I had a patient who was sexually abused by her father at age 6, and he was an alcoholic. And she freely admitted this, that she had been sexually abused by her father. And he would also bring his friend, who was the neighbor across the street, and would allow him to fondle his daughter as well. And when she turned, and this went on for several years, when she turned, the man finally moved that was across the street. When she turned 13, she again recalls being having to engage in intercourse with her father and also with other men in the neighborhood. She wasn't sure who those men were, but she knows that it did happen. She said that if she thought about it long enough, she could recall the smell of whiskey. She can recall the taste. She can recall the sound of breathing, and that's one thing she would say. I can remember their breathing and the urgency of their breathing. And so she goes into a place now that sells the type of alcohol that her father drinks. She would automatically have a panic attack because that smell had such a strong trigger. When she was 15, she was fondled by one of her teachers, who later found out was actually told it was okay by her father. So I saw her in clinic for the first time at age 22, and she came to me because she was having a real hard time concentrating and staying in school. She was having a hard time focusing. She was very bright, but was having a very hard time focusing, and she was having relationship issues. She could not maintain a relationship. She was in a relationship with a male and could not maintain that relationship and had no desire for any type of intimacy, and she thought there was something wrong with her. When she came to me, what she wanted is she wanted to be tested for ADHD, and she wanted something to help her with her decreased libido. We really started talking about her history and the impact of trauma, and disclosed that she had struggled off and on for years with anorexia, she had horrible problems with insomnia, difficulty concentrating, and also she was smoking marijuana and drinking alcohol at night. So this is a very good example of someone who had childhood trauma that has bled into adulthood and how it's having long-term effects. The substance use, would I be critical of her substance use? Absolutely not. What was that for her? That was a coping mechanism. Okay, so you can see I could have easily gone, yeah, sure, I'll test you for ADHD. I'll have you tested, and we'll probably give you something for your ADHD. And you're having a hard time sleeping, we'll probably give you something to help you sleep, a little trazodone, and then maybe we can start you on birth control pills and see what happens there. What have I just done? I've completely ignored the real issues. Unfortunately, she was very forthcoming. I alluded a little bit to the intimate partner violence case study, and this was actually a 42-year-old female, and she had actually filed charges. In the long run, I'd talked about she had left him, come back, left him, and come back. She filed charges against him, against her husband, after about 10 years of physical, emotional, sexual, and financial abuse. And she filed the charges. He actually did go to prison for attempted murder because he did strangle her, tried to kill her. But after it, she was told over and over and over again. She would come to see me, the shame and the guilt. She was told things such as, you should be over it. Aren't you glad? He's gone. He's gone to prison. You should be glad. You should be living life to the fullest. You should be so happy. When are you going to move on and meet somebody new? Don't waste any more time. This is what she was told. They sound like they were trying to be helpful and cheer her on, right? That's not what happened. I will tell you that a year ago, this coming December, she committed suicide. Human trafficking case studies, there are a million. What I really want you to take away from the human trafficking is that these women very often their first perpetrator was a parent. And so do not assume that they had any control over. They had no control over what happened to them. It may have been a friend of a parent. The stories I've heard are all different. Some women were blackmailed into it. In the case of adults, in the case of children, there doesn't have to be evidence of force, fraud, or coercion. But in adults, there's either force, fraud, or coercion. And they're told that I'll kill your family if you don't do this. I will tell you the one case I want to share with you that could happen to anybody we know. A young girl she was neglected at home. Her mother worked long hours. Her father was not around. And she was not a popular girl in school, and she made friends with one of the newer girls and several people. Was invited to a party, and she went to this party, and she was given the date rape drug. And she was sexually assaulted by an individual at this party. Well, it was videotaped. And when she came to the next morning, she was told that that video was going to her church, her friends, Facebook, to her parents, to her school, to everyone, unless she did X. And what that X was led to 3 more months of human sex trafficking. Okay? She was rescued. She should be happy. She was rescued. She was safe. Everything was fine. She was far from fine. She started using substances to cope with what had been done. She felt guilty that she went to the party. She never should have had that drink. Why did she dress the way she did? She is one of my current patients. And working with her, helping her see what was done to her and get past that. But now we're dealing with long-term hepatitis C. Now we're dealing with many other long-term health complications. And so just the rescue, just getting out of the abusive relationship, not only are you going to have to deal with that person's psychological fallout, you're also going to have to deal with physical things, chronic health problems. So what are our needs? We always need research. There is a growing body of research about victimization, early victimization, and problems later on in life. There's also a significant amount of research that needs to be done on the value of peer support. Peer support is an important way we know to engage those that have been involved. But one area that you have to be careful about is, and we see this with survivors of human sex trafficking, when we ask them to be a peer supporter and tell their story over and over and over again, guess what we're doing? We're re-traumatizing them. And the research needs to be done on what do we need in place? We have some supportive models in place, but really what do we need to do to help better care for those individuals' needs? Translation into practice. Once there's the research done, we need to translate into practice. SAMHSA has had their material out for a long time. We need to translate that into what we're doing. More education, educating providers, educating our patients, and educating the public. And again, implementing in individual clinics. It doesn't matter if you have a 1-provider clinic or you have a 10-provider clinic or you have a 200-provider agency. This can be applied at all levels. And it's not one person's job. Within the implementation, you have to identify a core team. And on that core team, you need to have some of the people that can make the decisions, but you need to have people in all areas of your agency there. And if there's anyone that you identified that has been through traumatic experiences they're willing to share, that you know of, bring them in as well, because they're going to be able to tell you more, engage what you're doing than anybody else. So as I finish, I want you to think about tomorrow. What are you going to do differently? What are you going to do differently tomorrow? Don't wait for your organization to make some big cultural change. You can start making change tomorrow. And I'll tell you that may be for the rest of today or tomorrow or this evening while you're driving home, or think about how you respond to trauma, your own biases, your own experiences, and maybe what you need to do to address that in the beginning. Because I can tell you, you will make a difference in a patient's life, and you may make a difference in a coworker's life, and honestly, your practice and the care you give will be better for it. Thank you.
Thank you, Dr. Hodges. It doesn't appear that we have any questions. Let me just double check one more time. No questions.
Okay, well, I'm very easy to reach. I freely give out my email address. It's Ashley Hodges, one word, @uab.edu. If you just want more information, if you are seeking to implement this in your area, or you just are curious, please feel free to reach out to me. The only way that we're really going to make a difference is by talking about this. This is what we've seen. We saw this with intimate partner violence for so long that we really didn't talk about it, and now we really talk about this. We saw this with human sex trafficking. We really didn't talk about it. I call those whisper words. You know, we'd say, you know, you heard about so-and-so's son. He's on drugs. You know, she was being trafficked. These are whisper words. She was being abused. Until we start advocating for these victims, it's going to fall on deaf ears. We've seen that with intimate partner violence. We're seeing that now with sex trafficking. So please do not hesitate to reach out to me for any questions you may have.
Thank you, Dr. Hodges.
Thank you.
This concludes our program for today. I want to thank Dr. Hodges for joining me, and thank you for watching. Please remember that you can refer back to the training and resources anytime on demand. Have a great day.